Hello everyone, it's Dr. Harim Jaffer. I'm periodontist. I'm about to finish to continue my previous lecture, which was about gingivitis, and starting a few other topics which are happening in the gingiva. I would like to cover everything about gingiva. So before I start, I'd like to ask you to subscribe my HL Talent website to get more videos on this subject. In the previous lecture, we talked about pathogenesis and classification of gingivitis, stages of gingivitis, clinical features, biofilm-induced gingival gingivitis without local factor, and biofilm-induced gingivitis with local contributing factor. We talked about gingivitis due to systemic factors, and we mentioned 7 systemic factors that are causing gingivitis. Today, we are covering 2 other topics, which are gingival bleeding and changes, mostly color changes, and we are talking in detail about gingival enlargement. So, we are starting with gingival bleeding and changes. As we know that the main determinant feature of gingivitis is bleeding, but not all the bleeding are inflammatory. So we have local factors for bleeding and systemic factors of bleeding. In the local factors that cause gingival bleeding, we have 2 types: acute local factors, chronic local factors. The acute factors that cause bleeding includes injury that occurs spontaneously in acute gingivitis. So one of the factors in the acute one is caused by injury or occurs spontaneously in acute gingivitis. Second, from acute bleeding is laceration from tooth bristles, sharp pieces of hard foods, etc. And another one causing acute bleeding is gingival burns due to hot food or chemicals. Another factor of acute bleeding is spontaneous bleeding in case of acute necrotizing ulcerative gingivitis. While chronic bleeding are seen in chronic and recurrent gingivitis, and also when we have a mechanical trauma, food impaction, and uses of toothpicks or biting into solid foods, and etc. So these are the local factors which present in acute and chronic form. While systemic factors of gingival bleeding, in case of hemorrhagic diseases, there may be a tendency of bleeding due to failure of one or more of hemostatic mechanisms. That say, it may be provoked by mechanical irritation, or sometimes it's totally unprovoked. So we have vitamin C deficiency, vitamin K deficiency, hemophilia, leukemia, Christmas disease, thrombocytopenia, purpura, and etc. And also bleeding may also be due to administration of excess amount of drugs, example salicylates, and anticoagulant like heparin. So these are the main systemic factors for gingival bleeding. So not all the gingival bleeding are purely inflammatory. You should take this into account. Regarding the color change, this is one of the most common thing also that we are seeing in the clinics. We know that the normal color of gingiva is coral pink, and it becomes reddish in inflammatory situations when the vascularization increases and the keratinization decrease, and also vice versa in case of when, for example here, when the keratinization increase, it look like paler, more fibrotic in nature when you are seeing it. So the color of gingiva may change according to the vascularization and according to the keratinization. In case of acute gingivitis, small bluish red area can be seen in the gingiva sometimes due to trauma from occlusion and also due to the presence of local irritants. Color changes may vary both by nature and distribution of gingivitis. Color changes may be marginal, as in acute necrotizing ulcerative gingivitis, and may be diffuse as herpetic gingivostomatitis. And it may be patchy or different as in acute to chemical irritation. Color changes vary depending on the intensity of the inflammation in the acute gingivitis. Initially bright red erythema can be seen, but in severe acute gingivitis, the red color change to shiny gray, which gradually become dull whitish gray. So according to the severity of inflammation, the color of the gingiva may change. And also we have color changes due to metallic pigmentation. Like for example, here or here. Color changes of gingiva occur also due to the heavy metal absorbed systemically, either due to occupational hazards or medicinal use. Bismuth, arsenic, and mercury products. These kinds of metals produce a black line that follows the contour of the gingiva. That's why I don't like the amalgam restoration, because of high level of Ag, mercury, which is toxic and may cause or may present an unpleasant color of the gingiva even after extraction. When a piece of amalgam entrapped to the site of extraction, it remains inside and you can't remove it unless surgically removed after that, and it will show itself underlying the gingiva. So also lead causes bluish red or deep blue linear pigmentation of gingival margin, and also exposure to silver cause violet marginal line accompanied by diffuse gray discoloration throughout the mucosa. Gingival pigmentation occurs due to a perivascular precipitation of sulfides in the subepithelial connective tissue. It occurs only in areas of inflammation because of increased permeability of blood vessels. Gingival pigmentation can be eliminated by removing the local irritant factors, some of them actually using H2O2. And actually chemicals are invasive. I don't consider it as a treatment actually. Some person may use it, but I don't like it as a periodontist because it's irritant by itself. It removes a color, but it may irritate the gingiva and cause another harms. Another pigmentation is melanin pigmentation. Melanin may increase in the Addison disease, which may appear as a patchy discoloration, varying from bluish black to brown color in the Addison disease, but sometimes may be idiopathic. We have idiopathic melanin pigmentation, in which the reason is just idiopathic. It's due to increase in the number of melanocytes, something physiological, Also, deposition of iron causes blue-gray pigmentation, just like a melanin pigmentation. And exogenous factors like atmospheric irritants such as coal, metal dust, coloring agent in foods or lozenges, tobacco, these may cause discoloration just like a melanin pigmentation. Also, there are some other diseases that cause or produce melanin pigmentation, like Pearce-Jaeger syndrome, Albright syndrome. These diseases may cause even not just gingiva, lip, and oral mucosa are included in the pigmentation. So, I like to talk about this subject because these changes may take our attention during diagnosis. And I prefer to talk about gingival bleeding in specific and the color change in specific. There's other changes, but we are talking about throughout the subject when we are covering the subject of gingiva. But these are the most prominent and important thing to know about the changes in gingiva and the gingival bleeding. So, we are jumping to gingival enlargement. Gingival enlargement have many causes, and still this is not only inflammatory. So we classify the gingival enlargement on the basis of inflammatory enlargement, which could be acute or chronic. We have drug-induced gingival enlargement, which we have, for example, 3 drugs that mostly cause gingival enlargement: dilantin sodium, nifedipine, and cyclosporine, which we talk about it in detail. And also we have combined both inflammatory and fibrotic gingival enlargement, and gingival enlargement due to systemic diseases. For example, leukemia, Crohn's disease can cause gingival enlargement. And also we have neoplastic enlargement. Benign and malignant tumors of gingiva also can cause enlargement. So it is not just inflammatory. Not every enlargement needs a surgical intervention, removal or excision of the gingiva. You should study well the history and examination that you are doing. And throughout the history, you may find the keys of diagnosis and treatment planning. So these are the classification. We are going to the acute inflammatory enlargement or gingival abscess. We are going through the clinical features, diagnosis, and management. The acute inflammatory enlargement results from bacteria which carry deep into the tissue. When a foreign substance such as toothbrush bristles, a piece of apple core, or a lobster shell, or a fish bone are embedded into the gingiva. So we have a trigger and we have an inflammation. The clinical features. Regarding the site, it's limited to the gingival margin or the interdental papilla, as we see here. This is gingival margin and this is interdental papilla. Regarding the onset, for every swelling, we should study these topics: site, onset, appearance. The onset is localized, painful, rapidly expanding lesion. That's usually of sudden onset. You have sudden onset pain. And the appearance in early stage, it appears as a red swelling with a smooth, shiny surface. But within 24 to 48 hours, the lesion usually becomes fluctuant and pointed, which may make a surface orifice from which an exudate may be expressed. And one of the most important features here is that the teeth the adjacent teeth are sensitive to percussion. So this is taken in consideration during diagnosis. So the diagnosis will be red swelling. When we see a red swelling with shiny surface associated with pain, it will give a clue to the diagnosis. And also we have laboratory diagnosis, which we are not talking about in details, but just a few points. For example, here there's a purulent focus in the connective tissue, surrounded by diffuse inflammatory infiltrate of neutrophils, and edematous tissue and vascular engorgement. Regarding the management of gingival abscess, the incision is the way of treatment of gingival abscess, actually, because we have a local irritant and we have inflammation. After topical anesthesia is applied, the fluctuant area of the lesion is incised with a blade, and the incision is gently widened to permit the drainage. And the area should be cleaned with warm water and covered with a gauze pad. After the bleeding stops, patient is instructed to rinse every 2 hours with a full glass of water. So every 2 hours, a full glass of water is to be used for mouthwash, as a mouthwash. So this is the management, clinical feature and diagnosis of the gingival abscess or acute inflammatory enlargement. While chronic inflammatory enlargement, regarding the etiology here, we have local factors and we have habits. Regarding the local factors, the etiology of chronic inflammatory enlargement could be caused by prolonged exposure to dental plaque, let's say neglected patient, which may occur due to poor oral hygiene, an abnormal relationship of the adjacent and opposing teeth, let's say crowded teeth, lack of tooth function. Sometimes patients use one side and don't using the other side, the non-using side, the non-functional side will be an area of aggregation of plaque, and chronically it will cause enlargement of gingiva. And also overhanging margin of dental restoration and improperly contoured dental restoration or pontics, let's say ill-fitted prosthesis. And habits in the etiology of inflammatory enlargement includes mouth breather. So most of the swelling here, most of the times, happen anteriorly in the anterior region. Okay. Sometimes you may find it generalized like here, but when the causes, the etiology is due to mouth breather, due to a habit like mouth breathing, so mostly the anterior region you see swelling. So here, to identify the case, you should know the clinical features. Regarding the site, the enlargement is generally papillary or marginal, localized or generalized, either affecting the marginal gingiva, free gingiva, or the papilla, or it could be localized or generalized. And the appearance of the swelling, it appears as a slight ballooning of the interdental papilla or the marginal gingiva. It's like a balloon. In early stage, it's like a balloon, and it produces a live preserver-like bulge. It's just like a live preserver bulge around the involved teeth. When you swim, you have a live preserver. When you are going to an ocean to swim, for example, you have a live preservers around your neck, and this swelling, just like that, when it will continue to grow, it will encircle the tooth like that. and it increases in size until it covers part of the crown. The color may be deep red or bluish red. They are soft and friable with a smooth, shiny surface and tendency to bleed. This is because it is inflammatory. All the inflammatory lesions have a tendency for bleeding. But it progresses slowly and painlessly until complicated by acute infection or trauma. Sometimes you find a discrete mass. Enlargement can occur as a discrete sessile or pedunculated mass in the chronic inflammatory enlargement. And they resemble a tumor. So they may undergo spontaneous reduction in size, don't be afraid, followed by exacerbation and continued enlargement. Painful ulcerations sometimes occur between the mass and the adjacent gingiva. Every mass will inhibit you from reaching the subgingival area. So it is one of the local factors that producing gingivitis. It's biofilm-induced gingivitis with local factors, as we talked about. Because these local factors will harbor in the plaque, will make the inflammatory process advance more in advance, so it worsens the condition. Here the diagnosis clinically, inflammatory enlargement with ballooning of papilla around the teeth will give us a clue to diagnosis. And also laboratorically, there's a proliferative features of chronic inflammations. And there's a predominance of inflammatory infiltrate and vascular engorgement. While regarding the management, we have removal of local factors. All of the local factors should be removed. Any plaque retentive areas, any habits should be corrected. So the second one, antibiotics, and the most common antibiotics here is metronidazole 400 milligram twice daily. And lastly, the flap surgery. We do periodontal flap surgery when it's necessary. So this is regarding the acute and chronic inflammatory enlargement. We are going to drug-induced drug-induced gingival enlargement. In the drug-induced, we have three main drugs that are causing the gingival enlargement. One of them, dilantin sodium, cyclosporine, and the other is nifedipine. Regarding the dilantin sodium, this drug, the other name of this drug is phenytoin, and it's an anticonvulsant which is used to control the epileptic seizure. A clinical feature here of this kind of swelling, at the onset we have a gingival hyperplasia which begins after 2 weeks of dilantin therapy. So you may face the symptoms after 2 weeks of using that drug. And the hyperplasia is usually generalized throughout the mouth, but most severe in maxillary and mandibular anterior region. Here and here, mostly anteriorly, and you can see it here. So the appearance, the first change noted is a painless bead-like enlargement of gingiva, starting with 1 or 2 interdental papilla. The surface of gingiva shows an increase in stippling, and finally a cauliflower watery, or pebbled surface. As the enlargement increases, the gingival tissue becomes lobulated, and clefts are seen between each enlarged gingiva. You see here lobulated gingiva, and here clefts between each lobes. Palpation reveals that the tissue is dense, resilient, and insensitive, and it shows little tendency to bleed. Here is the difference between the inflammatory and other causative factor of gingival enlargement. Here there's a little tendency to bleeding, despite you have a huge amount of swelling. And that's because that in this case, you don't have an inflammatory enlargement. Mostly bleeding due to vascular changes. That's why. The significance here, they may develop massively, as you see it in the picture, covering considerable portion of the crown, and they may interfere with the occlusion. The presence of an enlargement makes a plug control difficult, resulting in a secondary inflammatory process that complicates the gingival hyperplasia. So continuously non-controlling the local factor that harboring the plug inside the gingival crevice may worsen the condition. In hyperplasia associated with dilantin sodium, the presence of dental plaque doesn't seem to initiate the enlargement. You see a little amount of plaque here, but a huge amount of enlargement. That should give you a clue regarding the diagnosis. Additional studies have demonstrated that oral hygiene procedures may limit the severity of the lesion, but are unable alone to do a reverse of the condition. So you should manage the case, and we will talk about the management after that. The second drug that is contributing in the gingival enlargement is cyclosporine. And cyclosporine is a potent immunosuppressive agent used to prevent organ transplant rejection and to treat several diseases of autoimmune origin. But the patient who taken this kind of drug, clinically, the swelling is similar to that induced by dilantin. It starts in interproximal papilla, more frequently in the anterior facial areas, and partially covering the crown, as you see it in the picture here. It's a typical case of cyclosporine gingival enlargement. As an appearance, the tissue is usually pink, dense, and resilient, with a stippling or granular surface, and here also little bleeding tendency. Regarding the nifedipine, the action of nifedipine it's a calcium channel blocker, as we know, that induces direct dilatation of the coronary arteries and arterioles, improving the oxygen supply to the heart muscle. It's used in the treatment of acute and chronic coronary insufficiency. Here, gingival overgrowth occurs in 20% of the cases. The clinical and histological features are similar to that found in dilantin sodium and cyclosporine. Here the diagnosis, clinical diagnosis, including enlargement of the gingiva with history of drug, will diagnose the condition. So the history is very important. It takes a key role in diagnosing the case. And also, laboratorically, the stratified squamous epithelium that covers the tissue is thick but has a thin keratinized layer. And the retipecs that you have seen microscopically are extremely long and thin, and sometimes called test tube retipecs. And also you can see mitotic figures in the lab. So this is the drug-induced gingival enlargement. And as we said, we have also combined gingival enlargement in the classification. We said that in this type the enlargement will be both inflammatory as well as fibrous component. And we are not going to discuss this type because it is uncommon. Now we are going to describe the pregnancy-induced gingival enlargement. Here, the patient, it's by its name, should be female, and she should be pregnant. This will relieve you from a long way diagnostic procedure when you have a pregnant lady having a mass inside the oral cavity, so you are not going to think more about any other things except, or at least it will reduce the area of differential diagnosis for you. Here we have pregnancy-induced and puberty-induced gingival enlargement. Both of them are affected by hormonal changes. In pregnancy-induced, it can be marginal or generalized and may occur single or multiple tumor-like masses. When we have a marginal enlargement, it tends to be more prominent interproximally than on facial and lingual surfaces. The enlarged gingiva is bright red or magenta, soft and friable, and has a smooth, shiny surface. Bleeding occurs spontaneously or on slight provocation. Why? Because here we have hormonal changes. We have thinning or vascularization of the walls of the vessels that supply the gingiva. And in case when we have a pregnancy tumor, as in a picture that you are seeing, it's an inflammatory reaction to the local irritants. It usually appears after third month of pregnancy. So here we have a local irritant. So don't use an abrasive toothbrush, don't use toothpicks, don't avoid nail biting, pencil biting, etc. The appearance of the lesion appears as a discrete mushroom-like flattened spherical mass. It's like a mushroom that protrudes from the gingival margin, or more frequently from the interproximal space, and attached to a pedunculated basis, just like a tumor. It tends to expand laterally, more laterally. The pressure from the tongue and cheek can feel that flattened appearance mass, and the color is usually dusky red or magenta. It has a smooth, glistening surface that frequently exhibits numerous deep red pinpoint marking. The consistency varies from semi-firm, but may have a varying degree of softness and friability. So it's not a rubbery type of tumor. The symptoms It's usually painless unless its size and shape foster the accumulation of debris under its margin or interfere with the occlusion. So if there is no inflammation, no occlusal interference during biting or eating, so it's painless. But when you have an occlusal interference and a continuous accumulation of plug inside beneath the swelling, so the pain may be one of the symptoms. Diagnosis of this case is simply mushroom-like enlargement in pregnant lady. And we are not talking about the laboratorical diagnosis. Actually, it's not our subject. We may discuss this subject in different or separate entities. So the management will be simply maintenance of oral hygiene. Most gingival enlargement during pregnancy can be prevented by the removal of local irritants, and advising the pregnant lady for intensive oral care and continuous check and visit to the dentist throughout the pregnancy. I prefer each 3-month visit of pregnant lady for dentist to be checked and to be advised and instructed according to the stage of pregnancy. So this is pregnancy induced. Then we have puberty induced gingival enlargement. Here it's usually associated with the inflammatory type, because here also hormonal changes are affecting the condition. So the clinical feature here also, it's simple. Age and sex, both male and female in the pubertal age group are prone to that kind of swelling. It also appears in area of local irritant, but it eases the diagnosis, make it easier for you in diagnosis. Why? Because it's simply at the puberty age, and you seek for any local irritants, and the sites involve mainly marginal gingiva and interdental gingiva, as you see it in the picture. And it's characterized by prominent bulbous interproximal papilla, as you see it. Sometimes only the facial gingiva are enlarged, as the mechanical action of the tongue prevent heavy accumulation of local irritants on the lingual surface. So mostly the facial surface are involved, because the lingual one is continuously cleaned by the tongue and the saliva. So in each swelling that we studied, we should take into consideration that the plug control is one of the key features of reducing or eliminating that kind of swelling. So management here, the diagnosis is the bulbous enlargement, as we talked about. At the onset of puberty will give you a clue to diagnosis, while the management is the removal of local irritant. After puberty, the enlargement undergoes spontaneous reduction, but it doesn't disappear until the local irritants are removed. So it's not just age related, it's also related to the local irritants. So this is also about the pregnancy-induced and puberty-induced gingival enlargement. The diagnosis and management of all of these that we have talked about will be clinical based on clinical findings, laboratorical findings, but we are mostly dealing as a dentist, as a dental practitioners, as a specialist, mostly depending on the clinical diagnosis. And if we have to have, for example, a case which is difficult on us to differentiate it or to have a list of differential diagnoses to reach the actual diagnosis, we may need a laboratorical diagnosis, laboratorical findings, and the management. It's either surgical excision, or in case of drug-induced, discontinue or change the drugs, or use or advise the patient to use the optimal oral care in at home, or if the patient can't remove the plug and calculus well and the local irritants, he or she can visit the dentist for removal of the local irritants throughout scaling and polishing or root-planing or whatever it takes. So in each time you experience a swelling, you should take the advice from the clinician and experts to diagnose it for you and give you a proper treatment planning. And this is regarding the gingival enlargement that we covered today. I hope that you liked this subject and you are continuing on the gingiva. We try to discuss another subjects in another day to cover all or everything about the gingiva, or mostly the things that are most common to you as a clinician. Thank you for your listening. Have a nice day, and don't forget to subscribe to HL Talent to get more videos.